Hello, Dr. Waldron. Can you hear me?
I can, yes, thank you.
Hi, this is Jana from Epilepsy Support Network. We work closely with Brad, and he wanted me to do introductions for you, if that's okay.
Great, thank you.
Okay, well, it's so nice to meet you. First of all, welcome to Epilepsy Awareness Day, everyone, and thank you for joining us. It looks like we have some Orange County people on. This is great. Well, without further ado, we would like to thank and welcome Dr. Jennifer Waldron to this Epilepsy Awareness Expo. And thank you for your time and especially your topic. It means so much to so many families. And we welcome you and carry on and teach us everything we need to know.
Okay, thank you. Thank you for the kind introduction. And I'm actually going to turn off my video while I go through my presentation, but I will turn it back on for the question and answers part, okay? So can you hear me okay? Okay, so.
We can hear you okay.
Okay, wonderful, okay. So I'm going to talk, again, this topic today is a topic that is near and dear to my heart. We're going to be talking about mental health and children and youth with epilepsy. I'd like to start by thanking you for this opportunity to talk about a topic that I feel very strongly about. So as we know, all humans have emotions, regardless of the age or abilities. And how children express emotion, and particularly emotional distress and mental health disorders, does vary. And this is related to age, maturity, just inherent temperament and personality, as well as our abilities. In the last few years, I've observed in my personal practice that patients and their caregivers have had tremendous added stress. So in addition to the challenge of having or caring for someone with a chronic neurological condition, such as epilepsy, they have done so under the unprecedented circumstances of a pandemic, which has really disrupted our daily routines, our educational services, our therapeutic services, and even at times our medical services. In the last year and a half as an epileptologist, I've become more aware of the mental health needs of my patients. And through this sort of added insight and increased clinical interest, I've been able to better educate myself and I'd say increase my screening and even offer treatment for my patients for mood and behavioral symptoms. It was through this experience I've actually become more aware of the long-standing relationship between mental health and epilepsy. I really love this Fred Rogers quote for so many reasons, and it states that anything that's human is mentionable, and anything that is mentionable can be more manageable. When we talk about our feelings, they become less overwhelming, less upsetting, and less scary. I really love this for so many reasons. It acknowledges the inherent stigma of talking about our feelings and mental illness. It encourages us and urges us to talk about it in any ways. And in fact, talking about it is the first step to getting help. I think if there's one message I can sort of impart during this talk, it's to please talk to your doctor about your child's mental health. Share troubling behaviors, share embarrassing behaviors, share positive experiences, share what's working, share what isn't working, because this is part of epilepsy care and it's part of living well with epilepsy, and your doctor really is a key resource to help, whether they are able to participate in the management themselves or refer you to the proper person. So this is an image from the Disney Pixar movie Inside Out, and I love this movie. It does something really, really important. It, one, acknowledges that we all have emotions. A newborn baby has emotions, a child has emotions, parents have emotions, doctors have emotions. And emotions, even the hard ones like anger, disgust, fear, and sadness, are foundations to the human experience, and they all, in fact, serve important purposes. Secondly, it also shows that we experience our emotions differently. And very importantly, our emotions are really integrally related to our experiences and behaviors. So in pediatrics, I think it's important to recognize this and to recognize that mental health and behavioral disorders will manifest differently in different ages and in children and adolescents with differing abilities. So I'm going to sort of take a minute here to review sort of the objectives of what I hope to discuss during this talk. And I want to really emphasize this is not a comprehensive lecture on mental health. The purpose of this really is to sort of encourage you to talk to your provider and recognize some of these symptoms in yourself or your children. So again, we're going to review the prevalence of mental health conditions in children and youth with epilepsy. We're going to discuss some of the signs, symptoms, and treatments of several common mental health conditions, including the manifestations of these conditions in children who are nonverbal or who have intellectual disability. And we're going to focus specifically on anxiety disorders, depression, and attention deficit hyperactivity disorder, also called ADHD. We're going to discuss variables specific to mental health and epilepsy. We're going to discuss anti-seizure medications and adverse effects related to mood. We're going to talk about mood symptoms as a symptom of seizures themselves and as part of a broader epilepsy diagnosis. We're going to talk about the psychological and psychosocial variables specific to epilepsy and living with epilepsy. And we're going to talk about suicide. So the prevalence of behavioral and mental health conditions in children and youth with epilepsy. As we know, epilepsy is one of the most common pediatric neurological disorders in the US, affecting about 1% of people and about 500,000 children and youth living with epilepsy at this time. Children and youth with epilepsy do experience behavioral, developmental, and mental health comorbidities with a higher prevalence in children and teens without epilepsy. And so we know that behavioral symptoms are up to 4.8 times higher in children and youth with epilepsy than in the general pediatric population. Depression, anxiety, and behavioral symptoms are reported in about 1/3 of children and youth with epilepsy when compared to siblings without epilepsy. And this is interesting because we also know that it's underdiagnosed and unrecognized in children with epilepsy. So this may even be an underestimate. Living with a chronic neurological condition such as epilepsy with a mental health disorder, comorbidity during childhood and adolescence may have lasting impact on our overall well-being and a child's ability to achieve optimal health-related quality of life as an adult. In a study of children with epilepsy aged 5 to 16 years of age, 60% met the DSM-4 criteria for a psychiatric diagnosis, yet only 33% received psychiatric treatment. So we recognize that mental health and behavioral disorders in children with epilepsy are under-recognized and also undertreated. I feel this is very important, and that, one of my goals is to really educate parents as well as care as providers on the importance of screening and recognizing these disorders, and also understanding what the barriers are to why we aren't recognizing these. Why aren't these patients who do get regular medical care being identified? And I don't have all the answers for that. But it is imperative for doctors, patients, and caregivers to address and treat both epilepsy and comorbid mental health, developmental, and behavioral concerns. I'm now going to talk about anxiety disorders. So all children and adults have worries and fears. Anxiety is a very normal human emotion. It has an important purpose of actually, it's a protective mechanism. When you feel anxious, it makes you pause, look around. It's part of our nervous system for a good reason. It becomes disordered when it interferes with functioning and quality of life. And it's important to recognize that symptoms of anxiety look really different in different age groups. So when I'm seeing a patient and I'm screening for symptoms of anxiety, and like a young child, a toddler, or even a young school-age child, they can't really sit and have a conversation with you and say, this is really what's worrying me. What they'll do is they will become rigid. They'll have maybe excessive shyness, trouble with new places or people, and may even manifest with sensory sensitivities. They may be irritable. They may have trouble sleeping, and they, again, back to the sensory sensitivities, it's sort of subtle things and things that are actually quite common. But in little kids, if they say, they don't like how their clothes feel, or they are bothered by tags or seams on clothes, they prefer sweatpants to jeans, or they don't like their food to mix on their plate, or they eat things in a certain order, or maybe they're even extremely picky, which can be a normal symptom in childhood, but it can become really very problematic if they become overly sensitive to certain textures. And again, these symptoms aren't specific to anxiety, but we see this being sort of these are anxiety-based sort of symptoms to screen that would prompt more screening. So in older children, what we see is that they have more generalized worry, specific phobias, may have some obsessive compulsive tendencies, and may be able to describe symptoms of panic or have clearly discrete panic attacks, which we'll talk more about. So in the general pediatric population, anxiety disorders affect about 5 to 18% of children, depending on the study you're looking at. I'm sorry, I think there's a bit of a... So now talking about anxiety and epilepsy, the prevalence of anxiety disorders in children in youth with epilepsy is estimated between 16 to 50%, so clearly much higher than the general population. The risk factors for anxiety disorders in children and youth with epilepsy specifically are a lack of epilepsy-related knowledge. We see it at a higher prevalence in older age children, like young children, like teenagers. Increased seizure frequency, which understandably, if you're living with a high seizure burden, that can be very anxiety provoking, both related to safety and the social anxiety related to that, as well as sort of the duration of epilepsy. So treatment variables unique to anxiety disorders and epilepsy include, not surprisingly, seizure control, as well as anti-seizure medications, which may have anti-anxiolytic effects. So sometimes we'll pick a medication that may have dual effect to help with anxiety and mood. And some of the medications we think about are valproic acid, gabapentin, pregabalin, even vigabatrin, which I have not, and oxcarbazepine as well. Treatment includes cognitive behavioral therapy, and I will go into a little bit more about what that is here on one of the coming slides, as well as education focused on decision-making and communication skills specifically related to epilepsy, as well as pharmacotherapy. I'm now going to talk a little bit about types of anxiety disorders, and this isn't specific to epilepsy. This is just generalized symptoms to be aware of. So generalized anxiety disorder is sort of a generalized fear of everything. And children will have, again, excessive worry, often about many things, a tendency to catastrophize or make small problems larger than they are. Children may have physical symptoms, upset stomachs, vomiting, diarrhea, headaches, sort of an increased overall sensitivity to pain and just physical discomfort. And they may isolate or avoid common activities or people. Panic disorder is what it sounds like. It's a sudden and intense feeling of anxiety, fear, and panic. This may be unprovoked. It often is unprovoked, but also some children or adults with this can describe that they have clear triggers, like being in a crowded space, taking a test, feeling pressure. Sometimes athletics can provoke panic, sort of a performance type anxiety. And they may have associated feelings of physical symptoms like heart racing, sweating, shortness of breath, this feeling of impending doom, feeling lightheadedness or dizzy. And this can be quite profound. Patients will sometimes present to the emergency department because of the extremeness of these symptoms. And management of this involves relaxation strategies, including deep breathing, mindfulness, meditation, exercise, cognitive behavioral therapy, as well as exposure therapy, which again, I'll talk about a little bit more. 2 or more discrete panic episodes with a persistent fear of them happening again is diagnostic of panic disorder. Now we'll talk about treatment of anxiety disorders. So again, cognitive behavioral therapy, or CBT, is really the first line treatment. And this is a therapy that focuses on awareness of our thoughts and behaviors and emotions. And patients are really taught to recognize and adapt anxiety-provoking thinking with the goal of changing the patterns of thinking, changing their patterns of behavior, and also changing their patterns of avoidance. And this may include exposure therapy, specifically if there are specific phobias or panic disorder. Exposure therapy is a very intentional and repetitive exposure to a trigger, an anxiety-provoking trigger. And I think the thought over time is that if you continually introduce this, you will actually sort of lower that fight or flight response, and that you'll sort of, the trend over time will be less anxiety producing. It's not a pleasant thing for patients to go through exposure therapy. And it does take a very skilled psychologist or therapist to go through that. Again, cognitive behavioral therapy really can be done in younger children, but it does require that a child's able to talk. So that is one limitation in treating anxiety disorders in patients with epilepsy as well as intellectual disability that may be nonverbal. The other mainstay of therapy for anxiety disorders is selective serotonin reuptake inhibitors, or SSRIs. And I will talk a little bit more about the use of SSRIs in patients with epilepsy. We're going to shift gears now and talk about depression. Depression, again, like depression is I wouldn't say depression is a typical emotion, but feeling sad is certainly within the scope of human emotion, even hopelessness. But these are feelings that for most people are transient or relatable to a specific event that when it passes, the feelings themselves pass. So sort of the essential feature of major depression is a period of at least 2 weeks in which there's either a low mood or loss of interest or pleasure in most activities. And in children and adolescents, the mood may be more of an irritable as opposed to sad. You know, children may not be able to verbalize or express that the feeling is actually sadness, and it will manifest as more of a symptom of irritability and even anger. Other possible symptoms include changes in appetite, either up or down, weight gain or weight loss, either sleeping more than normal or sleeping less than normal, decreased energy, maybe a feeling of worthlessness or guilt, and difficulty thinking or concentrating or making decisions. Kids will have changes in how they're doing in school and their academic performance. And they may have recurrent thoughts of death or even suicidal ideation, which I'll talk a little bit more about how we screen for that. And the prevalence of depression in children in the general population is 1% to 2%, with increasing as kids get older. So in adolescence, it's estimated to be 3% to 8%. And by the end of adolescence, approximately 1 in 5 teenagers will have experienced at least one depressive episode. So depression in children and youth with epilepsy, the prevalence, as you can see, is higher. It's 23% to 33%. It does affect genders equally, and there are variables specific to epilepsy. And again, the variables associated with higher rates of depression include unpredictability of seizures, poor seizure control, lack of independence or autonomy. As you can imagine, for many children, there's already this sort of social stigma and this trouble with achieving these milestones of being able to drive, sleepovers, maybe participating in all the sports you would want. And depression is certainly related to that, not being able to spread their wings as maybe they would like, or as easily as they would like. There are additional risk factors that increase the risk of depression, both in children and in children with epilepsy. And this includes a family history of depression. Temporal lobe epilepsy is associated with a higher rate of depression. And we know that certain anti-seizure medications, including phenobarbital, Keppra, topiramate, perampanel, Onfi, others, can certainly exacerbate or cause depression as an adverse effect. And very interestingly enough, and again, I don't think we understand exactly why, there is a bi-directional relationship. So with the depression in of itself as a risk factor for unprovoked seizures and epilepsy. So there's a higher rate of epilepsy in patients with a prior diagnosis of depression. I'm going to now talk about suicide, and suicide is a hard topic. It's a hard topic to have in a lecture such as this. It's a hard topic to talk about one-on-one with our patients, and I think acknowledging that this is a very sensitive topic and that it can be uncomfortable is really important. But it's also extremely important that we be screening for this, and that parents and caregivers and patients are aware of this association in epilepsy. So suicide is one of the leading causes of death for children, teens, and young adults between the ages of 10 to 24. Suicide and suicide attempts are more prevalent in people with epilepsy compared to the general population. The rate of suicidal ideation ranges from 14 to 27% in children and youth with epilepsy. And I think really alarmingly, in a study, a self-reported screening study, 10% of teens without a known or diagnosed psychiatric comorbidity, reported suicidality at the time of routine epilepsy care follow-up. And the risk factors for suicide in patients with epilepsy include a diagnosed comorbid psychiatric disorder, as well as earlier onset of seizures. And so I'm going to pause here for a minute and talk a little bit about sort of how I talk about this with my patients and how I approach this. So as I've become more aware of this association and this rate, I have made it a point to screen my patients. When a child is sitting there very, very happily telling me about school, it can be awkward to pause and say, well, let's talk about this. But I think it's really important. I offer my patients the chance to talk with me in private. Many will take me up on that. Some do prefer their family to stay or caregiver to stay. I always share with my patients that, almost everything they share with me can and will be confidential, with the exception that if I feel if I assess that they are a threat to themselves or others, I will have to share that. When a patient does express thoughts of suicidality, I do have to then dive in and assess, how serious is this? Is this a passive, fleeting thought of, I don't want to be alive, or sometimes I feel hopeless, or is this really a discrete idea with a thought out plan and maybe even an intention to follow through? One of the things I like to screen for is, what are the protective mechanisms do patients have? Do they have a safety support group? Do they have someone they can talk to about these feelings? Are they already seeing a therapist or a psychiatrist? Are they having protective thoughts? Like when they have these thoughts, do they then think, oh, well, this would really hurt my family, or I really am scared to do this? So those are really important. And it's from there that I'm able to then really triage what needs to happen. And sometimes what needs to happen is patients that are actively suicidal do need acute emergent psychiatric care. They need to be evaluated by a psychiatrist in the emergency department. And I can tell you, when this happens, it can be very distressing to the family and the child. And sometimes, unfortunately, it's the first time the family may be hearing of these thoughts or understand the seriousness of how the child is feeling. So I want you to know that from my perspective, I always feel somewhat relieved when we uncover a child who's been thinking about this and no one knew. No one else in the room would have suspected it. So I hope that this is something you always feel comfortable talking with your doctor about, and I hope it's something that your doctor is screening for. I always provide my patients with some resources, including the National Suicide Prevention Hotline and the crisis text line. So I always put that in sort of my patient summary. And I always encourage my patients, if they need to talk, that they should call my office. I'm now going to talk about anti-seizure medication and suicidality. So the International League Against Epilepsy in 2013 did acknowledge a potential link of certain anti-seizure medications to psychiatric problems that may include an increased risk for suicidal ideation. But they emphasize again that the risk is quite low, and the risk of stopping or refusing to start anti-seizure medication treatment is significantly greater and carries associated increased risk of serious harm and even death. So I never, while I may choose an anti-seizure medication based on the risk of, the adverse effect profile screening related to mood disorders, I never discourage using anti-seizure medications, even in patients with severe depression or prior history of suicide attempts. So treatment of depression in children, again, you always are assessing for safety and screening for the risk of suicidal ideation. The mainstay of therapy is really a combination of both therapy and pharmacotherapy. And so again, we use cognitive behavioral therapy, family therapy, and group therapy. And the first line treatment of depression in children is an SSRI. I'm going to now shift gears and talk a little bit about, well, let me back up again. We'll talk a little bit about selective serotonin reuptake inhibitors, which again, should be the first line and in children with epilepsy. And these medications do have a favorable side effect profile. It is once daily administration, and there are not drug-drug interactions with anti-seizure medications. The medications we avoid are tricyclic antidepressants and buspirone, because these medications do lower the seizure threshold. I'm now going to talk a little bit about symptoms of depression and anxiety with children with epilepsy and intellectual disability. So approximately 1 quarter of children with epilepsy are functioning at the intellectual disabled range, which is an IQ of less than 70. And the presence of intellectual disability in children is associated with increased frequency of mental health and behavioral disorders. However, these disorders in children with intellectual disability may be under-recognized and undertreated. I think there is an assumption that intervention is not needed because the abnormal or atypical behavior is an inherent part of an intellectual disability. And this may lead to disorders being missed or undertreated. There can be, however, difficulties in diagnosing some disorders in the intellectually disabled population. And that's because the criteria developed to screen and diagnose these disorders may not be valid or testable in a child with intellectual disability, especially a child who's nonverbal. For children with significant cognitive deficits, there may be difficulties with regards to the ability to verbalize thoughts and feelings, and may make identification of significant symptoms more problematic. And so what I encourage families to recognize is just a change in behavior. So changes in sleep, changes in repetitive behaviors, changes in activity levels, changes in emotions, changes in patterns of social interactions and interactability. So that's something to be aware of. Again, related to that, there are specialists that are including developmental behavioral pediatricians, some pediatric psychiatrists, some neurobehavioralists that really specialize in the treatment of mood disorders and in patients with intellectual disability. And so again, it's very important that we talk about this so that we can refer to the proper provider to address any change in behaviors. I'm now going to shift gears and talk a little bit about attention deficit hyperactivity disorder, which is like near and dear to my heart. 1 in 10 school-age children in the US have a diagnosis of ADHD. And the prevalence of ADHD in children and youth with epilepsy is 30 to 40% in clinical-based studies. So this is a 2.5 to 3.5 increased prevalence, and then the general population. ADHD and childhood onset has a childhood onset before age 12, but again, can persist into adulthood and in retrospect may not be diagnosed until adulthood after reviewing symptoms in childhood. The symptoms are inattentiveness, impulsivity, and hyperactivity. And again, these look different at different ages. Inattention in a 3, 4, 5-year-old is going to look different than inattention in a 15 or 16-year-old. So a 5-year-old that's inattentive may just look like they're kind of daydreaming, whereas an older child, it may be more of a lack of attention to detail. They may look like they're paying attention, but they may not be able to organize their thoughts. Inattention in younger kids often is combined with the hyperactivity, whereas in older kids, that hyperactivity is often replaced with more of like maybe a fidgetiness or a restlessness, but they may not outwardly appear that hyper. Impulsivity is one of the most fascinating symptoms of ADHD, because in young kids, when I'm screening for impulsivity, I'm thinking about like, does your child run around Target? You know, does your child run away from you in a store? Do you worry that your child, without thinking, will jump in front of a car? Are you worried about your child's safety in public related to them running off? Whereas in sort of school-age children, impulsivity sometimes manifests more as like a social problem. Like, so kids will say things sort of impulsively and hurt their friends' feelings, or they will interrupt their friends or their teacher a lot. And in teenagers, again, impulsivity is part, you know, sometimes think of impulsivity as part of adolescence, but, you know, really problematic decision making, doing before thinking, as you would say. Again, the diagnostic criteria, you have to have multiple of these symptoms, though they can often be like a prominent inattentive or prominent hyperactive, or there may be a combination type picture. The symptoms need to have started before age 12, and the symptoms need to be interfering or reducing the quality of functioning, both like either socially, academically, or at home. And again, these symptoms do need to be present in more than one environment. So when we're screening for these, we usually do ask people to screen school-based symptoms as well as home-based symptoms. And the symptoms are not related specifically to another mood, development, or behavior disorder. Though I think it's very important to recognize that all these symptoms that we're discussing, both anxiety and depression and ADHD, have a lot of overlap. And so that's why it's really important to understand sort of what the root issue is. Is the issue a mood issue? Is it a behavioral issue? And sort of what's the underlying feeling driving this behavior? Is that while the behaviors may look very similar, there are diagnostic screening tools. I really like the Vanderbilt assessment scale. This is a screening tool that a teacher would fill out as well as a caregiver at home would fill out, and you'd compare the inattentive, the hyperactive symptoms against these two environments. Obviously, there will be some differences because the expectation on children is different at school and at home, but you usually actually see quite a similar pattern, or at least a similar proportion of symptoms in both settings. I also like this tool because it does actually have a portion that screens for other mood issues, including anxiety and depression and conduct disorders. The Conners Comprehensive Behavioral Scale is often administered by schools. And again, because a lot of these symptoms have sort of roots in various mood disorders, it may require a more comprehensive or neuropsychological evaluation and testing, which would be done through a neuropsychologist. I never hesitate to refer my patients if I'm not exactly sure what is going on, or if there may be multiple things going on, for additional testing. Sometimes this can be done through the school district, and other times we do it privately through a neuropsychologist. And I find that I'm able to get this covered from an insurance perspective, at least where I am, with a comorbid diagnosis of epilepsy more often than if they don't have a comorbid diagnosis of epilepsy. So the treatment of ADHD, the mainstay of treatment is really pharmacotherapy. The first line treatment is stimulant class medications. There has been some risk related to the discussion related to the theoretical risk that stimulants may increase the risk of seizures. But the most recent data does not support a statistically significant difference in the rate of seizures before or after treatment with the stimulant class medication. I will say I have a couple patients that once we've started stimulants, I have had a breakthrough seizure. Whether that is sort of an incidental thing or it's related, I've been able to continue the stimulant class medications by increasing our anti-seizure medication dose in the few times that this has come up, which is what I would do if a child had a breakthrough seizure without the stimulant variable. There are non-stimulant pharmacotherapy options, and there is behavioral therapy. And behavioral therapy really is the first line therapy for children less than 5 years of age. And behavioral therapy involves parent-child behavioral therapy and behavioral strategies, as well as social skills training, particularly helpful in older children and adolescents. We'll now talk about what contributes to mental health comorbidities and epilepsy. And again, it's complicated and multifactorial, and we don't have all the answers. Mood disorders and behavioral disorders are pervasive in childhood, but why is the prevalence increased in epilepsy? And what are the factors specific to having epilepsy that contribute? So the general risk factors, there's really no evidence that a child's age, sex, or socioeconomic status is associated with psychiatric comorbidities in epilepsy specifically. However, we do know that some of these variables do play into the risk of having psychiatric comorbidities. And so I think this is an area that, again, warrants a little more investigation, a little more research, and it also may be key to understanding why this goes so underdiagnosed and undertreated, and really targeting the patients that are not being caught. We do know that children with mild to moderate cognitive disorders have a higher risk of psychiatric comorbidities, and specifically, we think about low verbal IQ as a risk factor. So the pathology of epilepsy as a potential cause of neuropsychiatric symptoms, this is another thought. Is this all under one spectrum of the same? Is there really one disorder here, and these are symptoms of both? The Connecticut study of epilepsy looked to understand this, and they classified two groups of children with epilepsy, and they called the complicated epilepsy group, that's defined as a patient with a structural abnormality on their CT or MRI, and or a full-scale IQ of less than 80, which is low to low average. or lower. And in this group, defined as complicated epilepsy, 38.4% of children in youth with epilepsy had a diagnosed comorbid psychiatric disorder, compared to the group of uncomplicated epilepsy, which again is patients with epilepsy with a normal MRI with an IQ above 80. It was 26.6%. Specifically, there was a higher incidence of ADHD and conduct disorders in the group defined as complicated epilepsy. The rates of anxiety and depression between the two groups were similar, and later age of onset and epilepsy diagnosis was associated with an increased risk of anxiety and depression. Within the uncomplicated group, which again is the patients with epilepsy who have a normal structural MRI, as well as an IQ greater than 80, different psychiatric disorders were analyzed in different common childhood epilepsy syndromes. So they looked at benign focal epilepsy of childhood, childhood absence epilepsy, and juvenile myoclonic epilepsy, as well as others. And they did not find a specific association. But again, the purpose of this study was really to try to understand epilepsy in the context of sort of a broader neurodevelopmental disorder, and to understand why we see such higher rates and what the variables were. So then talking a little bit about trends over time, and does the risk go both ways? Again, that chicken and egg picture. Again, there's an inverse relationship between the duration of epilepsy and the rates of anxiety disorders. So again, we see in children and adolescents high rates of anxiety, but looking down into like adulthood and patients with epilepsy, we see lower rates. And this may be attributed to adaptive behaviors, acceptance, and education. This is not the case, however, with depression symptoms. Compared to new onset or newly diagnosed epilepsy, children and youth with chronic epilepsy report higher symptoms of depression over time. Some data does suggest higher seizure frequency or poor seizure control is related to an increased risk for ADHD. And like I've said, depression may predate seizures. So a prior history of depression is associated with a 2 to 5 time increased risk of unprovoked seizures or a new diagnosis of epilepsy. And this is true as well with children with ADHD. So children with a diagnosis of ADHD are reported to have a 4-fold increase risk for seizures when compared to children without a diagnosis of ADHD. Structurally, we know that the frontal and temporal lobes of the brain have implications in the neurobiology of depression, anxiety, mood, memory, and executive function. And so this is another area of interest and research, looking at these areas of the brain related to mood symptoms as well as epileptogenicity. So a behavioral, I'm going to talk a little bit more about anti-seizure medications. In 2008, the FDA issued a warning that anti-seizure medications have a 1.8 times increased risk of suicidality. And anti-seizure medications can have side effects of mood changes. So we know that Keppra, gabapentin, topiramate, perampanel have known behavioral adverse effects. Irritability and aggression are reported in about 10 to 16%. And psychiatric and behavioral side effects are the reason for discontinuation in about 11% of patients started on Keppra or zonisamide. A study of behavioral symptoms reported by parents 1 month after starting anti-seizure medications found 70% reported an increase in baseline psychological symptoms. So 28% reported increased hyperactivity, 25% increased anxiety, 23.8% increased symptoms of depression, and 16.9% reported increased aggression. So children, particularly younger children, do have a higher instance of behavioral adverse effects compared to adolescents. And we know that sort of baseline hyperactivity and impulsivity are predictive to behavioral adverse effects. So when I'm seeing a patient, I always warn the family, and if your child is particularly wired this way, more reason to be on the lookout. I will also tell families this isn't subtle, everyone's entitled to their bad day, and I wouldn't attribute every bad mood or every grumpy day or every off day to the medication. And that we really do need to trend these symptoms over some time, as in, days to weeks. We do know that polytherapy seems to have increased risk for behavioral adverse effects than monotherapy. And so what does this mean? Again, these are medications that these children and patients need. And we don't want to withhold important treatment. and we can't, but there may be a benefit to doing some pre-screening with psychiatric tools, screening tools, getting a good history of established or baseline anxiety and depression symptoms, and then also tailoring our anti-seizure medication choice to both the known seizure type as well as the clinical predictors for behavioral adverse effects that we can, with a pretty quick conversation, establish. So I'm going to summarize here and just review that mental health and behavioral health issues are common in children with increased prevalence in epilepsy, with the most common comorbid disorders are being anxiety, depression, and ADHD. The cause of mood and behavioral disorders in epilepsy is complex and multifactorial. Most importantly, mood and behavioral disorders are treatable, and your doctor should be discussing and potentially screening for behavioral side effects, mood and behavioral disorders as part of your routine follow-up visits. I urge you to please share any symptoms of depression, anxiety, ADHD with your doctor. Your doctor will be able to assess and the next steps in regards to a diagnosis, treatment, and refer to appropriate providers if indicated. So I'd like to sort of open up the floor to discussions and questions if anyone has any.
Okay, I think someone wrote a question in the chat that says, is clinging obsessively to specific items a manifestation of pediatric anxiety? And before we get to that answer, if you have questions, and some of you may be shy, just go ahead and put them in the chat and we will definitely get to them. Now's your time to ask all your questions, good folks. Okay, I will repeat it, the question.
Okay, so clinging obsessively to specific items, I would definitely take that as a serious symptom potentially of anxiety. I think it depends on the age of the child, but yes, I think that is a symptom of anxiety.
Okay.
It can also be developmentally typical. You can see kids get very attached to one toy. It's really if it's problematic to the child or problematic to the family, or if it's, in young children, we often see kids sort of cling to one toy or have a security toy. That it has to do with if it's really impairing that child's ability to function, or if they can't do anything without that security object, which even that is fairly typical up to about age 5 or 6.
Okay, I have a question, Dr. Waldron. Can you talk a little bit about how to encourage children to have healthy social relationships? Because I know if they have social support, especially from their peers, that can be very helpful with anxiety and depression. And what are your thoughts on that?
So I think that, assessing if children have a healthy social network is really important. For me, part of that does involve screening for bullying. I always ask my patients, are they being bullied? Are they being teased? I always ask, do you have at least one close friend, like one close confidant, someone that or is there like someone that you are close to outside of your immediate family? Because I think that's important. And families need to foster that for their children if they don't have that, whether it's at school or through another activity or a neighbor or even a cousin, but someone just slightly removed. I think it's important to sort of encourage a solid friendship, if not multiple solid friendships. I also screen for social media use. I find that is a source of social connectedness, but it's sort of a double-edged sword. It also can be a source of profound social stress. And I think it's important that parents understand that and are aware of what their child is doing. And I always like to know if my patients are having bullying on social media. As far as fostering friendships, I think it's important that especially like children and adolescents understand that what they choose to share with their friends is their prerogative. It's not like, I don't say you have to tell everybody everything about yourself. I don't think that's actually great social advice for any of us. But I always encourage them to be as open as they're comfortable being. If they are doing things like sleepovers, I think that it's important that an adult be aware of the diagnosis and the plan if there were to be an emergency seizure. But I also really try to encourage children to sort of be independent in that and have those conversations themselves as much as they're able to, sort of to empower them to sort of share what they can. And I honestly don't like to restrict a lot of activities. So, if I think it's important that while there may be some modifications, most children are able to do some part of a social activity.
Wonderful.
And so I always encourage families to really explore how to make that happen.
It's important, and we find it very, very helpful too at Epilepsy Support Network. So we practice that a lot, and that was a very comprehensive answer. So thank you so much. I'm taking notes, typing as I. We have another question. A 4-year-old who needs specific pieces of clothing and can't function without those items. What does that bring to mind for you?
That does sound like a flavor of anxiety to me. Again, at 4 years of age, how disruptive is this? Or can it be, am I as worried about it at 4 as I would be at 8 or 9? Probably not. But again, it depends on how disruptive that is to sort of that child's experience through the day. If they're crying 10 times a day because they left it in the other room, that's disruptive and that's upsetting and that's affecting their mental well-being. If it really is simply like, they just have to just stop and go get it a few times a day, that's less distressing, right?
Right.
So it's kind of on a case-by-case basis, but I would say it does pique my interest for anxiety. But again, we know that at 4, a lot of kids experience, there's again that spectrum of, is it an anxiety-based symptom or is it an anxiety disorder? And it has to do with how much it's disrupting the well-being of that child during the day. It's very common at 4 and 5 for a child to have a security object, and that's not discouraged at all. But if it's becoming if they're so rigid about it that they can't get through their day, then that becomes a bit concerning.
Oh, that's really good information, especially the years, so parents can adapt and adjust to that. So thank you, Dr. Waldron. Okay, we have a few more questions. Good job, everyone. I appreciate you posing the questions in chat. Okay, let's see. What is your opinion on the effects of zonisamide?
So zonisamide is one of the anti-seizure medications that can have, an adverse mood effect. Anecdotally, I see it less with zonisamide than I do with, say, Keppra. I never really shy away from trying zonisamide, though if a patient starts it and clearly has a decrease in their mood symptoms or doesn't like how they feel on it or they don't act themselves on it, then I would change. But that's how I do. That's true of any of the anti-seizure medications. I would say both zonisamide and topiramate, patients have reported feeling like less attentive, sort of spacey, as well as I've seen some increased symptoms of depression on both of those medications. Again, I don't necessarily shy away from using it, but I always educate my patients' families that if you're seeing these changes after starting it, talk with your doctor. And I will also say sometimes children over a month or 2 will adapt. So if it's a mild change, sometimes we just give it time. But if it's really profound, it's a conversation you should have with your doctor.
Oh, wonderful. Good point. Because side effects tend to start to dissipate at 2 weeks, so you may need to give it a little more time.
Yeah, sometimes, if it's not really profound or it's not disrupting your ability to function day to day, you can give it a little bit of time.
Okay. Okay, this is a question. I wanted to confirm you said buspirone lowered seizure threshold. I'm not familiar with that.
So Wellbutrin, yeah. So buspirone or Wellbutrin actually does have a black box label. It can lower the seizure threshold in patients with epilepsy as well as people who don't have epilepsy. So it is something to be aware of for that medication.
Right. Great. And the second part of that is this parent wanted to ask their doctor about this med because Ritalin helps her daughter focus, but increases verbal stimming and repetitive behaviors. She has epilepsy, autism, and ADHD.
Mm-hmm. So we do see that. So kids who have, so stimulants are, I mean, I love stimulants for my patients with ADHD. However, they can, in some children, increase, and it's not that they cause tics, but if you're already kind of wired for tics, or you're already kind of wired to do self-stimming behaviors, which it sounds like maybe the case here, it can increase those symptoms. You know, a slight amount of increased stim, or a slight amount of increased even tics, if they aren't bothersome to the patient, we don't get too worried about it. It's sort of a risk-benefit ratio. You have to sort of balance what's the more bothersome symptom and what's interfering with this child's functioning. If what you find, though, however, is that you really need the stimulant for the hyperactivity or the inattentiveness, but it's making these other symptoms markedly increase, sometimes what that's a symptom of is that stimulant may be actually provoking anxiety, and in which case you may try a different stimulant. Though I will say often they often do this, even, you may try multiple and have the same outcome. Or sometimes we add a very, very, very tiny dose of an SSRI. If we think the root of those other symptoms is an anxiety-based symptom and the stimulant is provoking that anxiety, we may try a little low dose, tiny dose of like an SSRI. I hate to chase side effects with other medications, but in this case, if you're really managing two problems, I don't think that's contraindicated.
Okay, thank you. Very good, and very direct information. Another great question. Is it important to have a social network which includes another person with epilepsy?
I don't have epilepsy, so I don't know. But I think that's a very interesting question. I think it is helpful. I'd imagine it is helpful. I think maybe a person with epilepsy might be able to answer that better. I don't know of any studies on that, but there probably are out there. I know that for myself, I find caregivers often really like to network with other caregivers of children with epilepsy. So I think it is sort of a part of the human experience to want to relate, there's a relatability we all want, with whatever we're dealing with. And so I'd imagine that may be important. However, I wouldn't force it on a child if they don't want it, or they're able to say clearly, I don't want this. I don't think you can force friendship. So I think it's something I would let a child, you could foster it and encourage it, but I wouldn't, you kind of have to lead the child to the resources and give them those opportunities. I don't know that you can, but I'd imagine it would be helpful. But I don't know. And honestly, that's one of the things I don't ask my patients is do they seek out other, my teenager patients? I don't know that I have actually asked them that. Are they actually seeking that out? I know that there are several local groups where I am, and there's social media groups, and that it tends to be more like parents and caregivers that are involved in those, or that share that with me.
Well, we have one of the parents in our group, Epilepsy Support Network, who has her daughter in our teen club, says, as a parent, it is very helpful to have a friend with epilepsy or be in an epilepsy support group. Thank you, Kathy. So
I'm sure it is. Yeah.
We hear this from our teens, even our little ones in Friday Friends Club, to watch them organically ask one another, you have epilepsy too? And so they can start that conversation and feel, as normative as can be, Mm-hmm. So I'm going to say, I think it's helpful, and it's a question you may pose to your child, teen, or young adult. And we do, if you look us up, Epilepsy Support Network, we're still online if you want to join us. So
and I will start asking my patients. I'll get more opinions on that.
We all learn so much, don't we? I love attending. We all, it's the questions that we're not asking that others ask that help us so much. Okay, so this is a long question. It's our daughter's being worked up for neurosurgery for her intractable seizures. She has temporal lobe epilepsy with damage to her hippocampus on her recent MRI. She has depression, anxiety, and panic attacks with a history of SI. The epilepsy team wants to hold off on neurosurgery until her depression is improved. The seizures contribute to her depression, so controlling the seizures would improve her depression. It's a catch-22.
This is a very, very, that's a hard situation, and I appreciate your question. without knowing the intricate details of your specific child's like MRI and EEG and seizure frequency, I can say that what would be most helpful and what you've probably already done is had very extensive neuropsychological testing. And whether or not you could, I think that you always want to, you're risking, there's always a risk benefit, like obviously epilepsy surgery may reduce your seizures but there can be other mood implications when you're having temporal lobe epilepsy surgery. And again, I would have to defer to the neuropsychologist to really, when they do their very comprehensive analysis of sort of the emotional and memory and IQ and verbal and language and all these, they can really kind of anticipate, sometimes they can anticipate what potential cognitive or memory or mood deficits would be after a surgery or a lobectomy. And so without really knowing all those variables, I can't really comment, but it does sound like a very tough position to be in.
Thank you, Dr. Waldron. We're nearing the end, so we'll do a couple more questions. One is, can you expand on low verbal IQ and mental disorder symptoms? My daughter has significant apraxia of speech.
So I think that for children who have low verbal scores and trouble with specifically expressive language, where they're able to talk, how they're able to actually verbally express themselves, communicate, there can be a lot of symptoms of frustration, a lot of symptoms of irritability. And so you really need to tease out, like, is it really an anxiety or irritability, or is it more of a frustration, which is understandable? And again, I think that it's sort of watching the pattern of behaviors over time and also seeing where the context of the behaviors is occurring. Is it happening related to challenges with communication, or is it happening randomly all the time, like unrelated necessarily to that? So I do think that, we know that children with low verbal IQ or low verbal, specifically expressive verbal abilities can have increased anxiety and frustration, mood issues. And again, that's when you kind of work with the therapist, the speech therapist, your doctor, your potentially treat an underlying anxiety and see how things go. But it's a multifaceted approach when you have a child with apraxia. You want to get all those therapies and and then potentially address the underlying mood component.
And another parent asks, what can parents do to support our children's mental health? Are there preventative actions for us to take before we see symptoms, in addition to fostering social peer connections?
So I think fostering the social peer connections, encouraging the child to be as involved in their epilepsy care as they can be, giving them that chance to talk to their doctor themselves, making this part of the priority of your visit. I know, when you see your doctor maybe 2 or 3 times a year, bring this up, talk about this. That way that it destigmatizes it. Do it in front of your child. Ask your child how they're doing. Give them names for emotions. Helping children name their emotions, that's a very basic, we can start this in toddlers. And so helping them identify their frustrations. If it's a nonverbal child, giving them nonverbal tools to express their emotions. It's really, really imperative.
Wonderful.
Mm-hmm.
Okay, and another parent has commented that it has been helpful for her child to be in a social skills group with other kiddos with epilepsy. And we have thank yous. So I will add to that and say, thank you, Dr. Waldron. This has been incredibly informative, eye-opening, and just another excellent presentation to credit Epilepsy Awareness Day and EXPO on this auspicious month of epilepsy awareness. So
it's been a pleasure. Thank you for having me. And thank you.
Thank you all for attending. We'll see you at the next presentation. Great job, parents, and great questions.
Thank you.